Thank you, Aftab, and thank you all the organizers for the wonderful course in Johannesburg. I'm sorry if I miss you guys very much. I should have been there, but I think there were some problems. That's why I couldn't get visa in time. The tuberculosis, which is not uncommon either here or in your part of the world, and I think most of the tuberculosis infection, the spine, they result into kyphotic deformity with a varying degree of neurological impairment. And or pain or paresthesias along with neurological impairment in the lower limb. If you look at the deformity, kyphotic deformity is one of the most common deformity in the most part of the world. And the 5% of the patient, in fact, they present with a fair degree of kyphosis, and which is more than 60 or so. This is because a lot of patients, they have backache and they have a deformity. They don't look into this seriously, and they don't present to any clinic or hospital in time, and with unchecked disease progression, they result into kyphosis. It is usually the gastrointestinal tuberculosis which result into retroperitoneal spread and ultimately through the retroperitoneal to the bits and plexus. It results into spinal infection, and but still pulmonary tuberculosis is still very prevalent, and a lot of patients, they have active or sub-active subclinical infection in the pulmonary tree, and from there it spreads to the spine. The extent of the deformity depends on the number of vertebrae they involved, maybe two adjacent vertebrae. That's usually the beginning, but as it is a disease advances, the vertebrae may be destroyed, or there may be more vertebrae they are recruited and produce pathological deformity. And it also varies according to anatomical side, the facet orientation, and then compensatory changes which occur because of kyphotic deformation, mainly in the posterior part of the spine, in which the facet may be dislocated, or they may be deformed, and the ligament and the muscles, they become incompetent, and they produce further aggravation of deformity. And the center of the muscle action in the abdominal muscle, and change in the center of gravity and the gravity forces, they play their own part, and they exaggerate or increase the deformity in an acute situation. If you look at the pathogenesis, there is usually hyperemia, osteoporosis after the Mycobacterium tuberculosis inoculation and inflammation. There are vascular changes, and that produces ischemic necrosis and the destruction of the adjacent vertebrae, which results into ultimately involvement of the intervertebral disc, and that results into collapse and progression of deformity occurs. And that, as I said, that abdominal muscle action, gravity, and loss of posterior spinal element that result into exaggerated kyphosis, and along with that, there's a gibbous formation into the canal, and that impinges the neurological structure, resulting into a varying degree of neurological compromise and presentation. As you know, it affects mainly the anterior elements of the vertebral column. More than 90% of the patient, only 10% of the patient, they have a tuberculosis in the posterior elements of the spine. which usually it is sort of mixed with the sensory the impairment, and they're taken as something entirely different. And the patient usually where they do not take much notice of that, and they present with a sort of advanced disease. And moreover, in the thoracic spine, the posterior column infection or the disease is not that easily detectable because of overlying ribs and the poor bone density in the posterior column. And it's only the MRI will give you a sort of a diagnosis, and it will pinch the sort of pathological event going on. Depending on the initial vertebral extent of the initial vertebral loss, various types of classes and healing is noted. Type A is when there is anterior column which is intact and the vertebral loss is minimal, and the fascia joints are intact, the muscle is still active, and there is spontaneous improvement occurs, but it increases the kyphotic deformity if it's more than 10 degrees. But less than 10 degrees, usually it will heal with the appropriate treatment. Type B is when there is sort of more than one vertebrae which are involved and lost in the disease process. And there may be a subluxation or a single level dislocation of the facet joint, and degree of deformity is less than 60 degrees. And the type C, when there is not only a sagittal rotation of the vertebrae, and there may be a sort of acute kyphosis, and there may be a anterior part of the vertebra which lies more horizontally and kisses the superior portion of the lower vertebrae, and there's a loss of more than 1.5 or maybe 2 vertebrae, and there's a dislocation of the fascia joint, and there may be a sort of a deformity which is more than 100 degrees. And these are the conditions, these are the degree of deformity which leads to neurological compromise, and patient may present with a paraplegia or spastic paralysis, and that results into sort of incompetence both anterior and the posterior column. The younger child, age less than that or lesser, with the active disease, they are more likely to progress rapidly. And if you have a vertebral loss more than 2 degrees or 2 vertebrae at the start of treatment, then progression is sort of more likely to be there. And if you have a thoracolumbar involvement, the degree of deformity will be much because of the transition of mechanical forces at the thoracolumbar area. And if you have advanced deformity at the time of presentation, something like more than 30 or 40 degrees, then even if you treat it medically, it will still sort of progress and which result into neurological compromise, because drugs to be effective, it will take its own time, and during that time, the progression of deformity will occur. One uncommon presentation, but severe presentation results into what is called as buckling collapse, when the kyphosis progresses to more than 90 degree of flexion. And it is not uncommon if it's untreated or been ignored, and the patient presents with a deformity, or it presents as in a childhood when the deformity progresses with the increase in age with the growth of the spine. And there is a multiple facet dislocation at the level of deformity. There is an instability, the post anterior and the posterior column, and there is severe kyphosis, and the entire spine is converted into large compensatory curves when they run parallel, just proximal and distal to the level of disease. And the capsular arm is usually is in a horizontal situation, and the both capsular and the chordate they are parallel to each other. And similarly, the spinal cord is draped on the top of this deformity, and they may sort of be sort of impaired in its function because of being stretching at the apex of the deformity, and also being impaired by the pathological process of pus being or this custom being impinging on the spinal cord. At the same time, the vascular changes can impose on top of that. If you have this deformity in a child, which has still some growth left, there may be a overgrowth of the multiple segment, and that contributes to the buckling collapse and the sort of parabolic type of deformity in this situation, and they may cause late onset paraplegia because of um, you know impaired function and scarring at at the top of deformity. Even if, as I said, the medical treatment is started, the progression of the kyphotic deformity is inevitable, and it will progress to a certain extent till it becomes effective, if they are going to be effective. The lesion can spread to adjacent parts, both proximal and distal. There is an increase in kyphosis angle, and the pus granulation tissue in this custom lead to further compression of neural tissue, along with the repetitive phenomena, and along with that, there may be some vascular element the plates part in kyphosis, and also neurological. The success of the treatment is the basic principle of the treatment is anterior deprima, followed by either leave it alone. But I think nowadays the technologies or the skills they are advanced enough that you should do the instrumented fusion. You should correct the deformity, and you should instrument from the back, and from the side. You should do the sort of fusion and correction of deblema and correction of any deformity, and you should remove all the offending pus, custom, any bony segment which are separated and which are sequestrated, and they're pressing on the spinal cord. You should restore the anterior column with a bone graft or with the titanium cages along with the bone graft, and that result into the restoration of the anterior column integrity, and posterior instrumentation result into augmentation of the posterior structures, and it will restore the all three column deformation. Bone graft with the structural allograft has been shown to be very safe when radical deprima is being done, but I think instrumentation should be done, and it's effective with a greater degree of fusion. Almost 95% of the patient they get fusion, provided they are instrumented from the back, and there's effective deprima to be carried out from the front, along with the restoration of bone deficit with a bone graft or the bone graft plus fusion cage. You can address all these things from the front and from the back, but if needed to, one can go in a limited extent to the front as well. You can use a costotransectomy approach to go from the front. You should not open the pleura. As 20% of these patients that they have active tuberculosis, and if you do the thoracotomy and open up the pleura, it can increase the morbidity and it can increase the mortality. So for these reasons, one should go from the instrumentation from the back, and one should go the paraspinal area through the costotransectomy 2 or 3 level, and you can do the instrumentation deblema and bone grafting from the front through the same posterior approach, and you can use various kind of devices, either graft or graft alone, or along with the cage, you can graft it, and it will stabilize the spine, correct the deformity, and will restore. It will allow the fusion to take place with the passage of time. Um, the posterior approach is good because it engages all three columns of the spine, restore the sort of mechanics very elegantly, and through the same approach, you can put a bone graft or the other cages in the, from the posterior side. And the costotrasectomy, which used to be carried out many years back, it has been sort of revisited, sort of reactivated, and I think it helps in, early recovery of these patients. Because in 20% of the patient with a tuberculosis spine, they have active tuberculosis of the pulmonary tree. And if you do the thoracotomy, then there's the risk of morbidity and mortality increase. So that's the reason that you should take a preoperative X-ray and you should avoid opening the rib cage or the not rib cage, but opening of the pleura, and the thoracotomy is to be avoided for the early recovery. You can do all these things from the front and back, but nowadays we don't do front approach because of its own morbidity and mortality. Even if it's a lumbar or thoracic lumbar or the thoracic area, you can approach all these things, all these areas from the posterior approach. This is one of the examples you've already seen, and this is a gross sort of problem with a thoracic spine. In this situation, one should go to the front, do the debridement, because you cannot address all this gross problem from the back, and you can do the anterior debridement. Then in the second stage, you can do the posterior instrumentation to stabilize the spine further. This is a CT scan of this lady. You can see this number of vertebrae which are destroyed or damaged in the pathological process quite extensive. And this is stage one procedure. And ultimately it was grafted, and fibrillar graft was put on. And the cage was also utilized in some other patient which is depicted there. These are expandable cages, but they are not empty cages. They also carry some graft, but there is a graft you can put on either anterior if there's a good space, and usually it is, and you can use also on the far side of the graft, far side of the cage. You can put a bone graft, and you can support this area with a various kind of cages or other devices or other material like you can use fibula. But rib is not a good bone. It's a good bone if it's morselized, but rib graft on its own should not be utilized because it does not provide stability. And once it dislodged, the sharp edges of the bone, they can damage the cord. So in active tuberculosis, posterior approach is very effective. It because spine is still mobile, and you can use instrumentation and posterior to anterior approach through the costotransectomy area approach. One can go anteriorly, and one can remove all the debris, remove all the dying and necrotic tissue, and you can put a bone graft or cage from the same costotransectomy incision. And I think a single approach can be carried out. But in a surgery which is established or the healed tuberculosis, the surgery is difficult because there is a gross distortion of the anatomy and the landmarks, and there's a ventral tethering of the pathological area, and there are additions around the dura, multiple involvement of the vertebral bodies with the apical mass of fibrous tissue with a new bone formation. And once you try to correct, there may be some further damage to the spinal cord or the blood supply to the area. And the second is that in the scar with the apex of the vertebrae, there may be pockets of isolated tuberculous area, which may be reactivated and produce late onset paraplegia in these patients. So the complication rate in established deformity is significant, and I think one should one should discuss it with the patient. One should evaluate it using various hematological interactive markers, and one should use a CT scan, and one should take care of, one should do the MRI, and that will give you not only bony involvement, but also with a soft tissue involvement, soft tissue extent of the scar and other things. And one will also have a look into the any potential pocket of abscess there within the scar area. That will be sort of visible on MRI. And if there's any area of reactivation, it should be assessed in both hematological and MRI examination. One can stage it if needed to. One doesn't have to be heroic in the established deformity. One can do it in a staged procedure that will allow the tissue to recover, allow the pathological process to be more sort of manageable, and it is effective, also safe for the patient as well. And again, not every patient with established deformity in heel tuberculosis is a sort of a candidate for surgery. One has to be a little selective. It all depends on the severity of deformity. Active disease, as I said, it can still be present, and the paraplegia or locational mobility can occur in this situation because of further damage to the cord and the further ischemic, particularly damage to the cord during the process of dissection and yeah, correction of deformity. And in this situation, if you're doing thoracotomy, thoracotomy will have its own complication, and one should be cognizant of this. The other challenge is the heel tuberculosis is the heel deformity, the disparity between the anterior and posterior column heights. If you have a multiple vertebral involvement with the presence of significant fibrosis, adhesions, and tethering of the dural or the anterior structure to the spinal cord, it may impair the spinal function and impair the sort of vascular supply to the area which is the seat of the scar. And the stenosis within the scar because of new bone formation, because of heterotopic bone formation, because of scar, and that adds to the further problem in surgical approach and surgical correction in this patient. Again, sensitive balance may be an issue, and these has to be considered sort of very seriously what you want to do with these, whether you want to correct the deformity without any significant risk or not. And if you want to correct just a surgical balance, whether the same region can be safely addressed or further surgery can be done away from the seat of deformity. And again, a special anatomical region has to be considered mainly in the occipital or the lumbosacral area, because these two regions, they have their own peculiar anatomy and particularly pathological anatomy, and they may need correction, and they may need sort of instrumentation and any kind of osteotomy, which is not without any risk. If you have a deformity in the lumbar spine, there are various kind of sort of deformities, kyphotic deformity, which is not in tuberculosis, but it's a general kyphotic deformity. It gives you an idea what kind of osteotomy can be carried out to correct this deformity and restoration of the sagittal balance. And this deformity, type of deformity, has been described by the Rajsekar. Type 1 is there's no column deficiency, and type 1A is mobile when the, like example is a Schumann disease, and type B is there's a fusion, there's no mobile segment, it's a fused including spondylitis. But there's no deficiency of the spinal column, but anteriorly or the posteriorly. Type 2 deformity is there's a one column deficiency which may be anterior or the posterior. Anterior is your trauma or infection, and tuberculosis comes into this type of deformity. And posterior column, there is a structural deformity which may be because of infection, may be because of post-laminectomy kyphosis or some other disease process in which the posterior column is not working, and there is a functional impairment in these patients. So one column which may be functionally not working adequately, or there may be a deficiency, structural deficiency of the one of the columns. And the type 3 is a type of kyphotic deformity when the both columns are either deficient in its structure or its function, and there may be a significant angulation at that given place, which may be less than 60, maybe more than 60, or there may be buckling collapse. These are deformities which are functionally impaired because of posterior structure. They are not working according to the expectation in a normal plan. There may be facet dislocation, there may be muscular sort of incompetence, or there may be deficiency of those muscles, and there may be anterior column which is not there, and they are a deficiency which is quite gross, and there may be a secondary impaired growth, which has resulted into further sort of a disparity between anterior and the posterior structures. In this situation, one can have a types of corrective osteotomy, which is treats imbalance of the spine in a sagittal plane. There may be a Smith-Peterson or Ponti's osteotomy. There may be a particular subtraction osteotomy, vertebral column resection, and vertebral column resection and lengthening, and the transpedicular decancellation osteotomy, which is a basal kind of osteotomy, or disc bone disc osteotomy. But again, these osteotomy, they are meant usually for the non-tuberculous, but if you're using in tuberculous, you should be careful whether you want to do the osteotomy at the same level or a different level, whether there's an activation, risk of activation of disease at the site of pathology, then you can carry at the same level. But risk of further damage to the spinal cord is there. It is a significant deformity, and it may impair any neurological compromise which may be there. So I think one should consider all these things and you should discuss this problem with the patients. Deformity can be corrected in these surgical procedures, which are variable. I have already explained. This may be a partial fascectomy or total fascectomy or a pedicle subtraction with a bone disc osteotomy or vertebrectomy, and multiple vertebrectomy with the restoration of the column both anteriorly and posteriorly. And in a buckling deformity, if there is any progression of neurological compromise, one can do the multiple vertebrectomy, but that carries a significant risk. But you can salvage that situation by just putting another bone block anteriorly so that there is no further collapse during the ambulatory or with the passage of time, and you can put a bone graft. These are the various kind of osteotomy which have been carried out, like preoperative field. Patient has a lot of backache with a neurological impairment. You can do the posterior pedicle subtraction osteotomy through the posterior approach with instrumentation which stabilize the whole situation. Another patient with a gross deformity, CT scan, which shows that there is acute angulation. It's more than 90 degree or almost 100 degree of angulation at the given level, which was clinically, you can see there's a sharp gibbous at the thoracolumbar junction, and she was treated adequately, and instrumentation was carried out, and she resulted into good functional and cosmetic outcome. For success of osteotomy in creating adequate sagittal balance. The selection is very critical to success. Preoperative radiographs and measurement of various degree of curve is important. Yes, Smith-Peterson is indicated in less than 30 degrees of deformity, but if you have a more rigid or severe deformity, VCR may be carried out, and the coronal deformity should also be corrected by asymmetric pedicle subtraction, because in tuberculosis, there may be is both the sagittal and the coronal imbalance, and one can correct during the same surgery. But again, one should be careful. One should evaluate the preoperative sort of neurological situation, and one should anticipate any further aggravation, and one should take care not to damage any further which is already there. And this is a general guideline for any surgical osteotomy, which can be carried out in various types of deformity. Type 1 is suitable for deformities of Smith-Peterson, and in selected cases, patients' collapse disc spaces can be corrected by the PSO, which are usually considered the larger deformity. Type 2 deformity invariably needs pedicle subflexion osteotomy, and it may need disc bone osteotomy. And again, all these osteotomy, they need posterior stabilization with the screws and rods. And the type 3 deformity may need VCR or single or multiple level vertebrectomy with a correction of both anterior and the posterior column. In these type 2 and type 3, you should maintain the balance, and you should do the laminectomy at the back, and you should make sure that there's no impingement or there's no sort of accordion type of problem in the dural sac, because once dura impinges at the junction level, it may impair the blood supply to the dural sac or the neural tissue, and may result into atherogenic. So in this situation, one should restore the anterior column height, and one should restore the balance at the posterior, and one should make sure there is no impingement of the dural sort of sac in the back, and that will, that might lead to ischemia and the damage to the cord. So in conclusion, in heel tuberculosis, deformity is there, and one risk of factor has to be evaluated. There may be potential difficulties and complication, and plan the osteotomy depending on the degree and extent of the disease, and also the mobility or the lack of mobility. And one should keep in mind that sagittal balance has to be corrected. And also, if there's any coronal problem, one should do the asymmetric part of the removal of bone, and one should maintain both coronal and the sagittal balance, yet maintaining the sort of integrity of the dural sac, and make sure there is no impingement of the dural sac at the junctional level, and make sure that there is adequate correction of the anterior column, because if the anterior column is not brought to optimal height, the posterior column is not restored adequately, which is balance the both anterior the posterior structures, and then the risk of neurological impairment because of ischemia can occur. So I think it is important to understand and make sure that patient understand, the surgeon understand, and the surgical skill is good enough to maintain the safety of the neurological elements and safety of the patient. And you should consider and discuss with the patient before going for surgery. Thank you very much. एक ना को दो